politician says AR-15 rounds create foot-wide exit wounds.
Floors in these hospitals begin to look more like a battlefield.
The firearms community says that's absurd, and they brought gel tests to prove it.
See if it came out the back. It didn't come out the back, but a little piece of frag came out the back.
I'm an orthopedic surgeon who has rebuilt the limbs and told the families. And I'm here to tell you that both sides are missing the same thing, the skeleton. And that changes everything. I'm Dr. Chris Raynor, orthopedic surgeon. I don't do political commentary. I do bone, joint, and occasionally vascular trauma, which means when a high velocity round enters a human body, I'm one of the people who deals with what it leaves behind. Here's what I'm gonna do today. I'm gonna take the 5.56, the most common rifle round in civilian and military use in North America, and I'm gonna show you exactly what it does to a human body, bone by bone. No political framing, no gel theater, just anatomy. And by the end of this video, you'll have a permanent framework for reading any wound ballistics claim from a politician, from a YouTuber, from a news report, and knowing immediately whether they're telling you the whole truth or just the part that supports their argument. Ballistic gel tests are part of this story. They're a useful tool. And one of the best controlled ones on YouTube was done by Garand Thumb, who I've collaborated with before. We'll use his data as a reference point, but gel is where the conversation starts, not where it ends. The skeleton is where it ends. Let's go. Here's exactly what we're doing. 5 acts. Act 1. I'm gonna show you how the AR-15 wound ballistics debate got this broken from both directions simultaneously. Because the politicians and the firearm community are making the same fundamental error, just with opposite political conclusions. Act 2, what ballistic gel actually measures. It's not what most people think, including most people in the firearms community. Garand Thumb actually explains this correctly in his own videos.
The reason we use ballistics gelatin is it's not exactly human tissue, or it's not approximating it, but what it does provide is a repeatable test medium that we can see relative ballistic performance.
The problem is the culture that watched him. Act number 3. The skeleton. This is the part nobody covers. We're going bone by bone. Femur, pelvis, shoulder girdle. And I'm gonna show you exactly where devastating in gel translates to dead in real life and where it doesn't. These are not the same place. Act 4, the framework. 3 zones. Every gunshot wound in the human body lives in one of them. By the end of this act, you'll be able to look at any wound ballistics claim and triage it in seconds. Act number 5, the verdict. Who gets this right? Who gets it wrong, and what the conversation should actually be about. If you get this wrong, the price isn't a bad opinion in a comment section. It's a tourniquet in the wrong place, a triage decision made on incomplete information, or a policy argument built on data that nobody bothered to translate into human anatomy. Those stakes are real. There is one bone in the human body that completely inverts the 5.56 survivability calculus, and it's the bone that neither the politicians nor the firearms community have ever mentioned in this debate. I'm gonna show you exactly which one at about the 10-minute mark. Everything before that is set up. Let's start with the shared error, because this is important, and it's gonna make some people on both sides of this argument uncomfortable. The politician who claimed AR-15 rounds create foot-wide exit wounds was wrong. The specific claim doesn't survive contact with basic ballistics data, and the firearms community was right to push back on it. If you've seen Garand Thumb's video testing that claim, where he fires multiple calibers into gel and shows the actual wound channels, the data is solid. The foot-wide claim is not accurate as a blanket description. But here's where the firearms community made its own error. They took that win and extrapolated too far. The argument shifted from that specific claim is wrong to 5.56 isn't particularly dangerous, the gel proves it. And that's where the skeleton walks into the room and the whole conversation changes.
Who invited that kid?
And it's worth asking why both errors persist so reliably. Politicians benefit from maximizing perceived lethality. It supports the regulatory argument.
Who in God's name needs a weapon with 100 rounds in a chamber? The weapon's only meant for one thing, to kill people.
Firearms advocates benefit from minimizing it. It supports the constitutional argument in the United States.
The only thing that's going to stop a bad guy with a gun is a good guy with a gun.
Neither group benefits from a nuanced anatomical picture that says it depends entirely on what the bullet hits. That answer doesn't fit on a headline or a thumbnail. but it's the accurate one. And accuracy is what we're here for. So here's the question I want you to hold on to before we get into the anatomy. Is the real problem the weapons, the misinformation, or the fact that neither side has ever brought a trauma surgeon into the conversation? Drop that into the comments. I want to see where this audience lands. And here's the framing I use to explain this to people outside medicine. Imagine you're arguing about how dangerous a car is in a crash, and both sides are only looking at the car's crumple zone. One side says the crumple zone is huge, therefore the car is deadly. The other side says the crumple zone is actually smaller than you think, therefore the car is fine. Neither side is looking at whether the driver was wearing a seatbelt, what the road conditions were, or whether the car hit a wall or a pedestrian. The crumple zone is the gel test. The seatbelt, the road, the target, that's the human anatomy. You cannot answer how dangerous is this car without knowing what it hit. You cannot answer how lethal is 5.56 without knowing what it hits inside the body. The gel tells you the crumple zone. The skeleton tells you the driver's outcome. We're moving to the skeleton. Imagine a patient, gunshot wound to the thigh from a rifle round. The wound channel in gel analog terms would have been classified as moderate. The bullet, though, had clipped the femoral neck at a specific angle. The patient exsanguinated before EMS arrived. The gel data said survivable. The anatomy said otherwise. That gap, that's what this whole video is about. This is the first of what might be a 3-part series on wound ballistics. Today, we're going to talk about the skeleton. Next, perhaps soft tissue, and why organ damage is the variable that gel tests actually do predict with some accuracy. And after that, the one I'm genuinely not sure I want to make yet is on what real-world trauma data says about 5.56 compared to handgun rounds. That one's going to upset people on every side. But let's get through this one first. Here's the part that flips the story. And credit where it's due. The best controlled 5.56 gel test that I've seen on YouTube actually explains this correctly. Garand Thumb's multi-barrel test, which we've already seen clips of, covers 10.3 inch, 11.5 inch, and 16 inch barrels, M855 and 68 grain hollow point at 25 and 125 yards. And we heard him say it, gel and human tissue are not the same. It's a consistent testing medium, helpful insight into how a round might behave. That's it, and he's right. The problem is not Garand Thumb. The problem is everyone who watched that video and translated devastating in gel into devastating in a human body without doing the anatomical translation step. Look at that cavitation. That is a visually compelling result. A large, explosive temporary cavity. And the instinctive interpretation, that would destroy a human body, feels correct because it looks correct.
As you can see, the depth of damage that it did, you can see how impressive it was on the high-speed camera, and you can see little pieces of it that broke apart before it exited.
But here's what gel cannot show you. Gel has no skeleton. A ballistic gel block cannot tell you whether that wound track intersected a femur, whether it clipped a pelvic ring, whether it passed 4 millimeters from an axillary artery. Those variables don't exist in gel, and they are the only variables that actually determine the clinical outcome. Okay, we've established why both sides of this debate are working from incomplete data, and we've seen exactly why gel, as useful as it is only half the picture. But here's where I need to reframe the whole question. We've been talking about 5.56 lethality as if it's a fixed number. It's not, it's a map. And the map is anatomical. What I'm about to show you is that map. And it's gonna make every wound ballistics argument you've ever heard suddenly legible. In the next few minutes, I'm going to walk you through the exact anatomical triage framework that trauma surgeons use when a gunshot wound patient comes through the door, bone by bone. Femur, pelvis, shoulder girdle. For each one, I'm going to show you the gel picture, then the skeletal reality, then tell you exactly which 5.56 wounds in that region are survivable and which ones close the case regardless of surgical intervention. Most people, including most firearms instructors and most ER residents, have never had this laid out explicitly. That changes right now. 3 zones: red, yellow, green. That's the entire framework. Everything I'm about to show you maps onto one of those 3 zones. Let's go zone by zone, bone by bone. We're starting with the femur, which, as I promised you at the top, is the bone that completely inverts the survivability calculus for every 5.56 wound discussion you've ever had. Here's why. The femur, the strongest bone in the body, and the most dangerous bone to take a 5.56 round near. Not because of the bone, but because of what runs immediately adjacent to it. The femoral artery runs along the medial aspect of the thigh, millimeters from the femoral shaft. A 5.56 round at combat distances fractures the femur. That's not in question. The physics are unambiguous. Comminuted fracture, bone fragments propagating through surrounding tissue, and a pressure wave that doesn't respect the artery's position. Two outcomes, and they're not equal. If the femoral artery is intact, survivable. Painful, surgical, long recovery. But the bone can be plated and rebuilt. I do this. Orthopedic surgeons do this routinely. If the femoral artery is transected, approximately 6 minutes of viable consciousness before hemorrhagic shock. Tourniquet or die. And outside a level 1 trauma center with a vascular surgeon immediately available, the clock usually wins. Now, here's the thing about gel tests and femoral wounds. The gel test looks almost identical in both scenarios. The wound channel, the cavitation, the fragmentation. All of it is essentially the same whether the artery is 4 millimeters away and intact or nicked by a bone fragment. The gel cannot show you the 4 millimeter variable. The anatomy can. Tactical question for the firearms community. Knowing that femoral artery involvement is the survivability variable, not the round, not the barrel length, should tourniquet placement be taught as a primary first responder skill before any other tactical medicine? Yes or no in the comments. Because the answer to that question is not obvious and the data is worth discussing. Stage 2 of 5, femur mapped. Next, the bone that keeps trauma surgeons awake at night, and the one that gel tests are least equipped to represent. Everything I just showed you about the femur, the millimeter variable, the 6-minute clock, the gel test blind spot, that's the entry-level version of this problem. The pelvis takes everything I just said and multiplies it by the structural complexity of 3 bones, a ligament system stronger than the bone itself, and nerve roots that control functions you will never get back. Here's what that looks like. This is a Tile C open book pelvic fracture. Military studies on combat pelvic fractures from gunshot wounds show transfusion requirements average over 25 units. Civilian data shows similar numbers. The external wound, entrance or exit, can be completely unremarkable. A small wound doesn't mean a minor injury. And no ballistic gel test in existence would have predicted that outcome. Here's the anatomy that explains it. The pelvis is 3 bones, 2 innominates and the sacrum, connected by ligaments that are in several locations stronger than the bone they anchor. When a 5.56 round hits the pelvic ring, the energy doesn't localize at the impact site. It propagates through the entire ring structure. The ligaments transmit force before they fail. The result is not a localized fracture, it's a structural failure of the entire ring. 2 scenarios, not equal. Scenario number 1, iliac wing. The big flat section of the pelvis you can feel at your hip. Mostly cancellous spongy bone. Major pelvic vessels are partially protected by ring geometry. This wound is serious, surgical, and survivable at a trauma center. Scenario 2, sacrum or sacroiliac joint. The triangular bone at the base of the spine houses the S1 through S4 nerve roots, the ones that control bowel, bladder, and sexual function. A fracture there is not primarily a survivability question, it's a quality of life catastrophe. You can survive a sacro GSW and spend decades managing bowel and bladder dysfunction. The gel test shows a clean wound channel. The body shows a life permanently reorganized. The engineering analogy. The pelvis is a load-bearing arch, a Roman arch. Every stone in compression against every other stone. Remove one stone and the arch doesn't crack. The force distribution of the entire structure fails. That's a Tile C pelvic fracture. The gel shows you the stone that was removed. It doesn't show you the arch collapsing. That's mortality north of 20%, even in a level 1 trauma center with full resources. Imagine another scenario. Trauma bay. GSW to the left gluteal region. Entry wound looked minor. Vitals are borderline. Bullet hits the sacral ala, fragmenting into 3 pieces, driving bone shrapnel into the presacral venous plexus. 24 units of packed red cells over 4 hours of surgery. That patient survives, but he uses a cane. Stage 3 of 5, 2 bones mapped, 1 structure left. And this one's gonna surprise you because it's the one that gel tests consistently make look most catastrophic. But in the OR, it's often the most reconstructible, the shoulder girdle. Here's a question that might genuinely surprise you. If you had to pick, based purely on gel test visuals, femoral neck hit versus a shoulder hit, which one looks more devastating? The shoulder almost every time. Mass cavitation, dramatic fragmentation, visually arresting. And yet, in my experience, I would take a shoulder reconstruction over a femoral neck with vascular involvement every single time. The gel test has that relationship exactly backwards. Let me show you why. The shoulder girdle, the area that gel tests make look like instant death, and the area where, more often than not, I can actually put the patient back together. A 5.56 round to the humeral head will shatter it. Grade 3B open comminuted fracture, bone fragments through the skin. That's certain. But the clinical outcome depends entirely on 3 structures that gel cannot show you: the axillary artery, the brachial plexus, and the 4mm margin between them and the bullet track. Axillary artery intact, the patient survives. Yellow zone. Shoulder reconstruction, possible replacement, chronic pain, reduced range of motion. Alive, functional, returnable to most activities. I've even seen this surgery. Patients go back to work. Axillary artery transected, 3 to 5 minutes before arm loss. Tourniquet as high and as tight as anatomically possible. Operating table within 90 minutes. Red-yellow border. The window is brutal and it doesn't extend. Brachial plexus involved. The patient may keep the arm and lose its function permanently. Drop wrist. Loss of shoulder abduction. Nerve damage does not regenerate on the time scale that bone does. This outcome doesn't show up in gel, doesn't announce itself in the immediate post-injury window, and is completely invisible in the wound channel. Here's the problem. The axillary artery can have an inner tear that doesn't show up right away. Hours later, a clot forms and cuts off blood flow. The patient looks fine initially, then they lose the arm. Wait and see, based on the wound's appearance, kills people. Gel tells you nothing about any of this. Nothing. This is where Garand Thumb's distance testing becomes genuinely useful clinical reference. His 10.3-inch Mark 18 data at 125 yards versus 25 yards shows reduced cavitation at distance. And the orthopedic literature supports that lower velocity means smaller temporary cavity, which reduces nerve stretch probability. But, and this is the part that doesn't show in gel, bone fracture does not scale with temporary cavitation. A humeral head hit at 2,000 feet per second or 2,500 feet per second shatters the bone either way. The gel shows you the cavitation difference. It misses the bone fracture equivalence. That's the exact blind spot we've been tracking through this entire video. Here's the framework. 3 zones, every 5.56 wound, every gunshot wound lives in one of them. Memorize these. Zone 1, the forever box, red. Central torso, clavicles to pubic symphysis. If a 5.56 round enters this box and fragments, any barrel length, any ammunition type, the patient has minutes to live without immediate surgical intervention. The aorta, vena cava, heart, liver, spleen, and the thoracic spinal cord are all resident in this box. This is where the politician's claim is closest to accurate. Not foot-wide exit wounds, but unsurvivable without a level 1 trauma center. Yes, no notes, no asterisk. The gel test is genuinely predictive here. Zone number 2, the limb grid, yellow. Femurs, humeri, pelvis. Survivable, but limb threatening. The variable is vascular involvement, and vascular involvement is invisible in gel. Zone 2 with intact vasculature is a reconstruction problem. Hard surgery, long recovery, good prognosis. Zone 2 with vascular transection is a tourniquet or die situation. The gel test shows you the energy transfer. It cannot show you which side of that line you're on. That inference requires anatomy. That's what you now have. Zone 3, the non-vital periphery. Green, buttocks, deltoids, calf muscles. These wounds look catastrophic in gel, large cavities, dramatic fragmentation. In humans, provided vasculature is intact, they're often survivable with manageable long-term consequence. Muscle regenerates. Peripheral nerves have limited regenerative capacity but are not the same as central nerve roots. Major vessels are not typically involved at these anatomical sites. The gel test overestimates the lethality of Zone 3 wounds significantly. This is where the firearms community is most right, and where the politicians' framing is most wrong. Here's the question that I think is actually at the center of the entire AR-15 debate, but nobody is asking it directly. If the public understood this 3-zone framework, if everyone knew that devastating in gel maps onto 3 completely different clinical outcomes depending on anatomical location, would the policy conversation be different? Or does the debate depend on both sides keeping the public ignorant of the anatomy? That one's for the comments. Because here's what I keep coming back to. The anatomical complexity of 5.56 wound ballistics is genuinely difficult to weaponize politically. You can't put it depends on which zone the round intersects on a protest sign or a campaign ad. You can't make a YouTube thumbnail out of survivable if the axillary artery is intact. Complexity doesn't serve either side's argument, but complexity is the accurate answer. And that's why neither side has brought a trauma surgeon into this conversation until now. Earlier, I mentioned that the best gel test data on YouTube was Garand Thumb's, and I stand by that. He uses it correctly, as a relative performance measure between ammunition types, not as a human tissue proxy. The firearms community that watched his videos and concluded 5.56 is fine made the leap he never made. And the politicians who cited media reports without understanding gel methodology made the opposite leap. Same data, same misreading, opposite political conclusion. So where does the anatomy leave us? What's the actual verdict on 5.56 lethality? And who, if anyone, in this debate is closest to getting it right? Here's my verdict as an orthopedic surgeon who has operated on the consequences of this round. 5.56 is not uniquely devastating compared to all other rifle rounds in all circumstances. That claim doesn't survive anatomical scrutiny. Zone 3 hits are manageable. Many Zone 2 hits are reconstructible. The firearms community is right that the most extreme political claims are exaggerated.
Unlike low gas prices, the dummy's still here. It's not obliterated.
5.56 is not just fine because gel tests show a manageable wound channel. That claim also doesn't survive anatomical scrutiny. Zone 1 hits are unsurvivable without immediate surgical infrastructure. Zone 2 hits with vascular involvement have a clock measured in minutes. The firearm community's counter-narrative overstates the case for it's fine. The accurate answer is the 3-zone framework. Red is unsurvivable without a trauma center. Yellow is survivable, but the window is narrow and the variable is invisible in gel. Green is survivable with manageable consequences. That's the whole picture. Neither side has been giving you the whole picture because the whole picture doesn't serve either argument. At the top of this video, I told you I'd settle the debate. Here's the settlement. The debate has been conducted in the wrong medium. Gel is not anatomy. Political claims are not clinical data. And the honest answer to how lethal is 5.56 is not a number, it's a map. The map is 3 zones: red, yellow, green. Now you have it. The round doesn't decide the outcome. The anatomy does. Learn to read the anatomy. Last question for the comments, and this is the one I genuinely don't know the answer to. Is the public better served by a simple narrative, even an incomplete one, than by the anatomical complexity? Or does the complexity actually matter for policy? I want to hear what you think. If you want the next layer of this, what happens to soft tissue and organ when a high velocity round passes through and where gel tests are actually most useful, then let me know in the comments because that's the next video in this series. The soft tissue picture is where gel starts to earn its keep. Potentially a 3-part series. Skeleton today, soft tissue next. And then the data comparison between 5.56 and handgun rounds that nobody wants to make. Because the answer is gonna complicate every position in this debate. I'll see you there. Otherwise, as always, that's been a word from Dr. Chris Raynor, not your everyday ortho, where we see one, do one, teach one.